Hello everyone, welcome to GIE author interview. I am Mohamed Abdallah. I am a second year gastroenterology fellow at the University of Minnesota, and I'm here with Dr. Trikudanathan, a therapeutic endoscopist and an associate professor at the University of Minnesota, and we are here to discuss our paper, Visceral artery pseudoaneurysms in necrotizing pancreatitis, risk of early bleeding with lumen-apposing metal stents. Dr. Trikudanathan, welcome to the GIE author interview. Can you tell us what made you conduct this study?
Thank you, Mohammed. Mohammed, as you may be aware of, at University of Minnesota, we manage a lot of necrotizing pancreatitis patients, and we carry one of the largest prospective database. This has been going on from 2010 all the way to the present date, and we have managed around 675 patients, not just with one modality of management. We manage them with endoscopic step-up approach or with adjuvant percutaneous drainage, and some of them end up needing open necrosectomy. And gastrointestinal bleeding is not uncommon in the setting of necrotizing pancreatitis. It could happen from routine causes such as ulcers, erosions, but it could also happen during the procedure when we try to dilate the cystoenterostomy tract. But we were specifically interested in pseudoaneurysmal bleeding. And we were also specifically interested in pseudoaneurysmal bleeding in relation to lumen-apposing metal stents, which are being increasingly deployed for management of necrotizing pancreatitis these days.
I see. So why you think pseudoaneurysms develop?
Very good question, Mohammed. So pseudoaneurysms could arise from enzymatic degradation of the arterial wall. It could also be the necrosis directly eroding the arterial wall. But commonly, it could be traumatic damage to small vessels and especially arteries when we perform endoscopic necrosectomy or with percutaneous drainage or during open necrosectomy.
I see. Perfect. So can you tell us how did you conduct this study?
So we identified all the necrotizing pancreatitis patients between 2010 to 2020. There were roughly around 607 patients in our prospective database. We retrospectively went about looking at all the cross-sectional imaging, being the contrast-enhanced CT or the CT angiography or the IR performing visceral angiogram. We looked at all those reports, and we identified pseudoaneurysm patients from this entire cohort of necrotizing pancreatitis patients. Among this, we then compared the patients who underwent pseudoaneurysms and the patients who patients who had pseudoaneurysms and patients who did not have pseudoaneurysms, and we compared their, the baseline demographics, the severity of the disease, also the organ failure between the two groups, and also the endoscopic and percutaneous or open necrosectomy interventions between the two groups.
Excellent. And what are the main findings of this study?
So we identified 39 patients among 607 to have developed pseudoaneurysm. That's roughly an incidence of 6.4%. And among the patients, among these 39 patients, 7 of them had not undergone any form of intervention. In other words, even patients who were managed conservatively could develop pseudoaneurysm. But patients who were managed with endoscopic or percutaneous drainage were more likely to develop pseudoaneurysms compared to patients who have not undergone any interventions. And we also identified the splenic artery to be the cause for pseudoaneurysms in roughly 50% of the patients, followed by the gastroduodenal artery. The in-hospital mortality among patients who had pseudoaneurysms was roughly 23%.
I see. And can you tell us about the association of lumen-apposing metal stents with the development of pseudoaneurysms? I think you mentioned earlier that lumen-apposing metal stents are being used increasingly for management of fold-off necrosis. What about their association with pseudoaneurysms?
A good question, Mohammed. Uh, we were specifically interested in the relationship of lumen-apposing metal stents and pseudoaneurysms. But interestingly, the choice of the initial cystentrostomy stents did not determine the incidence of pseudoaneurysms in our population. In other words, if patients are managed with lumen-apposing metal stents or plastic stents, that did not really matter. However, patients who were managed with lumen-apposing metal stents had an earlier incidence of pseudoaneurysms. In other words, patients managed with LAMPs had an incidence of pseudoaneurysm at 47 days compared to 109 days managed by other interventions, which we thought was an important finding. And also, nearly half the patients managed with lumen-apposing metal stents developed pseudoaneurysms within the first 3 weeks after deployment of those stents.
Interesting, interesting. And why do you think this happened? Why do you think lumen-apposing metal stent accelerated the development of pseudoaneurysms in these patients?
So lumen-apposing metal stents, as you know, has a large inner diameter. So this facilitates rapid drainage of the necrotic contents. So once the necrotic contents are drained, the vessels in the necrotic cavity are exposed to the inner flanges of the lumen-apposing metal stents. They are also exposed to the remaining residual solid necrotic material, which in turn could weaken the arterial wall and predispose for them to develop pseudoaneurysms.
So what is the message that you want to convey to the readers of GIE?
So I think patients who undergo management of necrotizing pancreatitis with lumen-apposing metal stents could develop pseudoaneurysms at an earlier stage in their disease process. So these patients should undergo interval cross-sectional imaging within 2 to 3 weeks after their deployment. And in this cross-sectional imaging, we should be carefully identifying pseudoaneurysms or vessels impinging on the inner flanges, and then we should remove the stents right away. That way we could avoid pseudoaneurysmal bleeding, and that way we could optimize our outcomes.
Excellent, excellent. Well, thank you very much for discussing this paper. We hope that the readers of GIE find our paper to be interesting and useful for their clinical practice. We would like to thank the editorial board at GIE for this wonderful opportunity.